You know that feeling? That rumble in your stomach, maybe a bit of that uncomfortable fullness after eating? I think it's something pretty much everyone can relate to at some point.
Oh, definitely.
But imagine that discomfort becoming like a persistent gnawing pain, something that really just throws off your whole day. That's kind of the territory we're getting into with peptic ulcer disease, or PUD.
Exactly. Yeah, while the occasional dodgy stomach is, well, just life, PUD is more serious,
Mm.
we're talking about actual open sores developing.
Open
Yeah,
source.
picture the lining of your stomach or the very first part of your small intestine, the duodenum. It gets breaks these erosions.
Oh, okay.
That's an ulcer. And it happens because stomach acid and those digestive enzymes essentially wear away that protective lining. So
Hmm.
when we say PUD, we mean both gastric ulcers in the stomach and duodenal ulcers.
Gotcha. So for this deep dive, we're digging into your revision notes on peptic ulcer disease. The plan is really to pull out the absolute must-know info to give you a really clear, memorable grasp of PUD, sort of your high-yield PUD crash course, if you like.
Precisely. Yeah, the aim is to boil these notes down to the core stuff, the key facts that are hopefully going to stick.
All right, let's go back to that definition again, just to make sure we've got it locked down. These open sores in
Yeah,
the stomach lining or that initial bit of the small intestine.
that's the one. And the basic mechanism is this erosion caused by the very things meant to digest our food, stomach acid, digestive enzymes. But here's a really crucial bit.
Okay.
The vast majority, and I mean the vast majority, of these ulcers are strongly linked to a specific bacterium, Helicobacter pylori. You often
Wow.
just hear it called H. pylori.
H. pylori, yeah, that name pops up a lot with stomach problems, doesn't it? How strong is that connection with peptic ulcers?
Oh, it's incredibly significant. The data we have suggests H. pylori is implicated in, get this, about 95% of duodenal ulcers.
95%.
And around 80% of gastric ulcers. It's a huge link.
Wow, okay. That's definitely a massive piece of the puzzle. So, H. pylori is clearly the main player here, but what else can, contribute? What other factors are involved in causing these ulcers?
Right, so while H. pylori is definitely the #1 cause, other things can weaken the stomach and duodenum's defenses or sort of ramp up the aggressive factors.
Okay.
Your notes list quite a few. NSAIDs, that's non-steroidal anti-inflammatory drugs, are a big one.
Like aspirin, ibuprofen.
Exactly, those common painkillers. Then there's pepsin itself, the digestive enzyme. Smoking is another major factor, alcohol consumption too.
Right.
Bile acids, steroid medications, even stress can play a part. And interestingly, your notes mention potential changes in the consistency of gastric mucin, that protective mucus layer, where maybe genetics could even have an influence.
That's quite a lineup alongside H. pylori. Is there maybe a handy way to try and remember those other contributing factors? A mnemonic, perhaps?
Yeah, memory aids can be super useful.
Mm-hmm.
How about something like no pain, so bad, always stresses mucin. So that's N for NSAIDs, P for pepsin, S for smoking, B for bile, A for alcohol, S for steroids, S for stress, and M for mucin consistency.
No pain so bad, always stresses mucin.
Right. It's a bit weird, but sometimes those are the ones that stick.
Exactly. Quirky works.
Okay, so we know what can cause them, but who's more likely to actually get them? What are the key risk factors we should be aware of?
Well, there's definitely a lot of overlap with the causes, as you'd expect. But thinking about who's more susceptible,
Right.
it's probably no surprise that H. pylori infection itself is a major risk factor. Regular use of those NSAIDs we mentioned, aspirin, ibuprofen, that significantly bumps up the risk. Alcohol and smoking are definitely on the list. If you've had PUD before, you're unfortunately more likely to get it again. Being older increases risk too, as does significant stress. And, like we touched on with the mucin, there seems to be a genetic element, so a family history of PU or even gastric cancer might increase your risk. Thinking about these helps us sort of flag individuals who might be more vulnerable. Okay, so we've got causes, we've got risk factors. What's actually going on, like, inside the stomach or duodenum when an ulcer forms?
The pathophysiology.
Yeah, basically PUD happens when there's this imbalance. You've got the aggressive factors, think acid, pepsin, and H. pylori doing its damage,
Right.
versus the protective factors, the mucus layer, bicarbonate that neutralizes acid, good blood flow for healing.
Like a defense system?
Exactly like a defense system. And when the aggressive team overpowers the defense, it leads to damage to that mucosal lining. If that damage goes on long enough, it can erode right through, creating those open sores, the ulcers.
Right, the defenses get overwhelmed.
Yeah.
Makes sense. Now, if someone comes in with symptoms that sound like PUD, How do you tell it apart from other things? What else could it be? The differential diagnosis.
That's a really critical point, yeah, because lots of things can feel similar. Your notes give a pretty comprehensive list of conditions to consider.
Gourd gastroesophageal reflux disease, heartburn, that's a really common mimic. Gastritis, just inflammation of the stomach lining can feel very similar too.
Right.
Then you got to think about nearby organs, gallbladder issues, pancreatitis can cause upper abdominal pain. Non-ulcer dyspepsia is a big one. People have the symptoms, but when you look, there's no actual ulcer.
Okay.
More seriously, you absolutely have to rule out gastric or even duodenal cancer. And then the list goes on. Abdominal aortic aneurysm, Crohn's disease, diverticular disease, IBS, hepatitis, even things like Zollinger-Ellison syndrome, which causes massive acid production, and sometimes even coronary artery disease can present with pain up there.
Wow, that is quite a list. Really highlights why you need to investigate properly. So how common actually is PUD? What's the epidemiology look like?
Well, interestingly, the overall rates of PUD seem to have decreased a bit in recent years.
Oh, really?
Yeah. But your notes point out that duodenal ulcers are generally still more common than gastric ones. The peak age for getting diagnosed is usually between 55 and 65. And there's a noticeable trend for it being more prevalent in lower socioeconomic groups. To give some context, that general upper tummy discomfort, dyspepsia, affects maybe 40% of people each year, but only about 5% of those actually go see their GP about it.
Right.
And only about 1% of those end up having an endoscopy. But when they do have an endoscopy for dyspepsia, the findings are quite revealing. About 40% turn out to be non-ulcer dyspepsia.
Oh.
Another 40% show signs of GERD. Ulcer disease itself is found in maybe 13%, gastric cancer in about 2%, and esophageal cancer in 1%.
That breakdown is really helpful context.
It is, yeah. And while PD is declining overall in Western countries, H. pylori still keeps it relevant in certain groups. Globally, the sort of reported incidence for diagnosed PD is somewhere in the range of 0.1 to 0.19% per year, and hospitalizations run about 0.03 to 0.17%. Gives you a feel for the scale.
Definitely. So, okay, if someone does have PUD, what are they actually likely to feel? What are the typical clinical features?
The classic symptom, the real hallmark, is that epigastric pain or discomfort, right in the upper middle part of the abdomen.
Epigastric. Okay.
Yeah. People often describe it as like a burning or a gnawing feeling. And a really key feature, particularly with the duodenal ulcers, is that the pain often gets better when you eat or take antacids.
Okay. That's important.
Very. Other common things are nausea, maybe some vomiting. And if it's more severe, people might lose their appetite and even lose weight. The timing can be a clue. Too often kicks in maybe 1 to 3 hours after a meal. It can even wake people up at night. But again, food often makes it feel better.
Right.
Some less specific things might crop up, like burping a lot, feeling bloated or distended, finding fatty foods hard to tolerate. Occasionally heartburn, though that's more typically GERD.
Okay.
And sometimes, if the ulcer is on the back wall, a posterior ulcer, the pain can radiate through to the back. Yeah. And like we said, antacids usually give at least some temporary relief. But it's also crucial to remember that not everyone gets obvious symptoms.
Silent ulcers.
Exactly. Particularly in older people, men, smokers, those with H. pylori, and strangely, those without a condition called atrophic gastritis. So you can't always rely on symptoms alone.
Right.
On examination, if it's uncomplicated, you might just find some tenderness when you press on that epigastric area. And here's that memory tip again. It's quite useful. Gastric ulcers often get worse with food. Think gastric growls. Duodenal ulcers often get better. Think duodenal dissolves.
Gastric growls, duodenal dissolves. I like that. Makes it easy to remember. And what about bleeding?
Yes, vital. Signs of upper GI bleeding are a red flag. That could be vomiting blood hematemesis or passing those dark, sticky, tar-like stools melena.
Got it. So if PIU is suspected, based on all that, what tests are usually done to actually confirm it?
Right. The investigations kind of fall into two main camps.
Right.
First, testing for H. pylori infection. And second, actually looking inside to see the ulcer and maybe take samples.
Makes sense.
For H. pylori, you've got non-invasive options, like a urea breath test or a stool antigen test checking the poo for bits of the bacteria. There are also blood tests for antibodies, though they have limitations.
Right, they just show past exposure sometime.
Exactly. They might not show an active infection. The breath test and stool test are generally preferred for detecting active infection. Your notes mention the carbon-13 urea breath test specifically.
Okay.
Then for visualization, the gold standard is usually an upper endoscopy. A flexible camera goes down.
The OGD.
Esophageal duodenoscopy, yeah, the OGD. Lets the doctor see any ulcers, check their size, location, take biopsies to confirm H. pylori right there, and importantly, rule out anything more sinister like cancer, especially with the gastric ulcers.
And biopsies are key for that.
Absolutely. There's also the older barium swallow X-ray. But endoscopy gives much more information and allows biopsies, so it's generally favored now. Oh, and a full blood count might be done too, checking for anemia, which could suggest chronic slow bleeding from an ulcer.
Right, iron deficiency anemia.
Precisely. And the notes specifically highlight doing that endoscopy fairly promptly if someone presents with new symptoms and they're over 55.
Okay, age is a factor.
Yes, or if they have any specific alarm symptoms, regardless of age.
Ah, yes, the alarm symptoms. What are those again? The red flags?
Yeah, the ones that really make you want to get that camera down there quickly. Your notes list them clearly. Iron deficiency anemia is one. Any other sign of chronic blood loss, even if it's subtle. Unintentional weight loss. Progressive dysphagia, that's difficulty swallowing, getting worse.
Yeah.
Persistent vomiting is another major one. And finding a palpable mass, a lump, in that upper abdominal area.
Right. Is there a mnemonic for those?
There is. How about, I can't wait to please even more.
Okay, let's break that down.
I, iron deficiency anemia. C, chronic blood loss. W, weight loss. P, progressive dysphagia. P, persistent vomiting. E, epigastric mass.
I can't wait to pee, please, even more. Excellent. Very memorable. Any other reasons for endoscopy in over 55s?
Yes, even without those big red flags, endoscopy is often considered in people over 55 if they have a history of a previous gastric ulcer or previous stomach surgery or pernicious anemia. Also, if they're regular NSAID users or have a family history of stomach cancer, it widens the net a bit.
Got it. Those mnemonics are genuinely helpful. So, okay, you've done the tests, PUD is confirmed.
Yeah.
What's the game plan for treatment, the management?
Okay, so management really hinges on a few core things, according to your notes. Number one, if H. pylori is found, you've got to get rid of it. That usually means a course of antibiotics combined with strong acid-suppressing
It's
medication.
eradication therapy.
Exactly, triple therapy often. Second, if NSAIDs are the likely culprit, the ideal thing is to stop them, or at least reduce the dose or switch to something else if possible.
Makes sense.
And third, lifestyle factors. Quitting smoking is important, cutting back on alcohol, managing stress. These all support healing.
Right. And the acid suppression.
Yeah, medications to lower stomach acid are crucial. Proton pump inhibitors, PPIs, are usually the first choice things like omeprazole, lansoprazole. Sometimes H2 blockers like ranitidine might be used, but PPIs are generally seen as more potent.
Okay. So it depends on the cause.
It does. If it's H. pylori positive, the absolute focus is eradication. If it's H. pylori negative but clearly linked to NSAIDs, you stop the NSAID and use a PPI note, say PPIs work better than H2 blockers here.
Right.
And then there's the tricky group, H. pylori negative and NSAID negative.
What about those?
Then you need to dig deeper. Look for rarer causes like Zollinger-Ellison syndrome, maybe rebiopsy to check for unusual things.
Okay. And what if the ulcer is actually bleeding?
That's an emergency situation. Usually requires urgent endoscopy to find the bleeding point and try to stop it directly, maybe with clips or injections.
Gotcha. And preventing it coming back. Recurrence.
Good question. Nice guidelines. Mentioned in your notes. Emphasize confirming H. pylori is gone after treatment. And for gastric ulcers, a repeat endoscopy is usually recommended to ensure it's fully healed and definitely not cancerous.
And you can't use the blood test to check eradication, right?
Correct. Serology, the blood test, is only for initial diagnosis, really. You need a breath test or stool test to confirm eradication. And for people who have to stay on long-term NSAIDs, regular H. pylori checks might be needed, and maybe even long-term low-dose acid suppression with annual reviews if they keep relapsing.
Okay, that's a clear strategy. So if someone gets the right treatment, what's the outlook usually like? The prognosis?
Generally, it's actually very good these days. With the right treatment, most ulcers heal up pretty well, usually within weeks to a couple of months.
That's reassuring.
It is. The main issue is recurrence. If those underlying risk factors aren't dealt with, if H. pylori isn't eradicated properly, or they keep taking NSAIDs without protection. But serious problems are, thankfully, much less common now than they used to be.
Okay. And what are those potential serious problems, the complications, even if they are less common?
The main ones to be aware of are bleeding, as we mentioned, vomiting blood or melena. That's probably the most common serious complication.
Right.
Then there's perforation. That's where the ulcer basically burns a hole right through the stomach or duodenal wall.
Yeah.
Causes sudden severe pain. It's a surgical emergency.
Ouch. Okay.
Gastric outlet obstruction. This happens if an ulcer near the exit of the stomach causes swelling and scarring, blocking food from passing through properly. Leads to persistent vomiting, feeling really bloated.
Right.
And finally, although it's relatively rare, there is a slightly increased long-term risk of developing gastric or duodenal cancer, especially with chronic, untreated H. pylori infection.
Yeah.
Definitely something to keep in mind, though, again, not common with proper management.
Okay, so let's quickly recap our deep dive on PUD. We're talking open sores, stomach, or duodenum. H. pylori is the big cause, along with NSAIDs. That burning epigastric pain, often better after food, is classic.
Yeah.
Diagnosis involves H. pylori tests and usually an endoscopy. Treatment targets the cause, kill the bug, stop the drugs, lower the acid, change lifestyle.
Spot on.
Prognosis is generally good, but complications like bleeding, perforation, obstruction, and a small cancer risk are possible.
You've got it. And it is quite fascinating, isn't it, how this common little bacterium or everyday painkillers can cause such disruption to a really fundamental process like digestion.
Yeah.
Makes you think, what other maybe seemingly small things might be having quite significant knock-on effects on our health that we don't fully appreciate yet?
That's a really interesting thought to end on. Definitely food for thought. Right, well, for further study and loads more resources on this topic and pretty much everything else relevant for the MSRA, make sure you check out pastthemsra.com.
And don't forget freemsra.com for, well, free resources too.